Thank you very much. Tēnā koutou. It's at this stage that I feel obliged to present my mihi, and I have been doing research into my whakapapa, my tūranga waiwai, and really trying to improve my te reo. And I finally understand that actually to do it properly, it's quite a process. So my personal challenge for that I will have that completed by the next conference, and I do throw it out to everybody in the audience to make it your personal challenge too, because we really are in a sexual and reproductive health environment in New Zealand cultural context, and I think we should take a look at what that cultural context looks like. So my name is Heather Young, and ko Tarangi Ingarahi. I've got basically Scottish descent. I was born and bred in Dunedin, Otepoti, but not on the Otago Peninsula, under the shadow of Saddle Hill and near the Taieri River. I've got 2 children. I currently work at the Sexual Health Clinic, which is a lovely place in Christchurch, and I've been given the brief of doing STI guidelines and everything in the guidelines update in 2017 in 15 minutes. So I'm not known for my brevity, so I'll do my absolute best. The reason for the blank space on the top left-hand corner of the slide is on purpose. It represents my wish list. So my wish list is to have an enduring contractual future process for biannual guidelines living update, because this is going to become a bigger and bigger and bigger process, with particularly probably the Ministry of Health funding logo there, and the primary care, something such as a Goodfellow unit in the University of Otago. The other thing I would like to see there is the logo of the College of Physicians and the College of General Practice with the appropriate endorsed CME points. And as was discussed at the AGM yesterday, I really think we need to have a process of embedding these into day-to-day practice, because thank you Rose Forster and Helen Roberts, who sent out the Women's Health Review just recently. There was a thing in Auckland that said 10% of people in the Auckland region their gonorrhea was managed appropriately according to the guidelines. So we can write whatever guidelines we want, but if no one knows they exist and they're not following them, then we're not doing our job. So with that in mind, cut to the chase, they say. Most of you in primary care will need to go, and you've done very well to stay to the last session. I've got these lovely logos here for a good reason, and I think that in the future we're going to have to be really savvy in our partnerships to gain political leverage as to what we want our sexual health environment to look like. You can see that the New Zealand AIDS Foundation just yesterday have done some fantastic advocacy work and have been really helpful to us. Just the Facts, likewise. We have associated strongly for this round of guidelines with the STIF Foundation. We've borrowed heavily from our much greater funded partners across the Tasman, the Australasian Society, and they're now for sexual health, HIV, and viral hepatitis, not just HIV medicine. So we're part of the ASHA Alliance. Now you'll see MedSac off there in the corner by itself, because we don't align with them, but they have launched relatively recently. They have the new name for what used to be called DSAC. And in the past, sexual health, we always had a sexual assault satellite symposium, and I would like to challenge us going forward to make much stronger links with that and continue that, because they're an excellent society. And family planning here seems to be absent. We've had a little bit of a divergence with the 24-hour telephone line and our closer links with family planning, so we're really working on possibly coordinating conferences and things with them in the future. So for those of you, I often don't finish on time. I put the executive summary at the start, and that the STI management guidelines, really we want to really increase frequent opportunistic testing, particularly contact tracing, and we've had discussions about that today, the use of nucleic acid amplification testing techniques, and antimicrobial stewardship. So that's by following the guidelines, you use the right antibiotics at the right place at the right time. There was a case earlier today of urethritis, and it was treated with amoxicillin, and I'm thinking, do a lot more rectal and oropharyngeal swabs particularly, and you notice we've raised the age from 25 to 30 based on our local epidemiology, and actively recruit, recall and test males. You may have to outreach to venues to do that, because if you stay where you are, we're clearly not reaching the male demographic. Never assume the gender and number of sexual contacts of the person in front of you, particularly if that person is a male. Never assume he has a female partner, and never assume, even if he does have a regular female partner, that he doesn't also have other sex contacts. There are several new tools that have come out, and you've heard about some of them in the last conference to combat STIs, but we really need to improve partnerships with other sexual and reproductive health organisations, and I would include all of Māori Health, and I always feel sorry when there's parallel plenary sessions that I never get to the other health promotion sessions. We need a lot more research, surveillance data, and this is internationally, particularly Ministry of Health targets, KPIs, demonstration of core competencies in primary care, and they're saying don't be too political, and a lot more resourcing for quality sexual and reproductive health care because we are at capacity at hospital sexual health services. What are our responsibilities? So this is the World Health Organization Rio de Janeiro conference in July of this year, and the upshot of it all is that gender equality, women's empowerment, access to contraception, maternity and abortion services, sexual health and human rights is actually the heart of global development. So I've always said that sexual health is the be-all and end-all of everything, and that if you get sexual health indicators right, all of health follows. Well, it turns out that I'm right. The United Nations agrees with me, and that HIV, STIs, and human rights are the major determinants of global health. So you could say that sexual health is the outward expression of your total mental, physical, emotional, and spiritual health. And that, to me, is a very Maori model of healthcare. It's acknowledged that sexual and reproductive health services must be based on quality research and surveillance, and politicians particularly must play a part in translating this research that we've been hearing about into funding and policy, and we've got to be really strong advocates for that. So this is actually the definition of quality healthcare. The World Health Organization has parameters of what quality care looks like, and STIs is probably the archetypical quality healthcare thing. So, you know, I'm supposed to have all these disclosures of these funded research and things that we're doing, and of course I don't have any, but I am on the New Zealand Sexual Health Society Guidelines Writing Group, and that's not just me, that's a big team of people, and they've been fantastic, and the STIF Professional Advisory Board for Warts and Herpes. And why would I disclose that? Well, it's because this is really an absolutely shameless promotion of these guidelines here, and the devil really is in the details. You know, every single word has been agonised over to carry out all the ifs, ands and buts, and it throws up a lot of information about systems that we don't have. You know, national laboratory standardisation, any lacks in research, any lacks in surveillance data, guidelines that we don't have become very obvious. So we launched the summary of guidelines a few weeks ago at a Dunedin Quality Conference, and this weekend we're launching the longer guidelines on the new look New Zealand Sexual Health Society website, plus also the Warts, the Herpes and Just the Fact website. And this is really to go with the Sustainable Development Goals that the World Health Organization has put forward, following on from the Millennium Development Goals that expired in 2015. So I think we have a global responsibility to the World Health Organization Western Pacific region, a national responsibility to us in New Zealand, and we have personal responsibilities, and that was what I was mentioning with my mihi. So I was actually looking at the Ministry of Health website, and this is the New Zealand Maori Health Strategy, and I actually interpreted the conference theme as Paora. Now, I know that health promotion doesn't always use those models, and I was fascinated to hear about the Te Whāriki Takapau Pohiri model. I think that's fantastic. But overall, to me, all models, you know, are heading towards the same thing. But interestingly, the youth health system level measures for vulnerable youth populations are actually sexual health key performance indicators. However, unlike key performance indicators, there's no national target for system-level measures. And I think, you know, given that we're supposed to be founded on Treaty of Waitangi principles, I think that that's not all right. And also, just as the Ministry of Health website have launched this, they've disestablished some of the Māori health policy section. That's like taking one step forward and two steps back. So I've deliberately chosen an environmental picture here because we have to look after our environment, and I'm not just talking about, you know, clean water and clean air. I'm talking about our sexual health environment. I'm talking about our funding environment. and I'm talking about the environment that we have in each of our individual clinics. So we need good data, evidence-based guidelines, and a human rights approach to advocacy. Sexual health is Māori health. Sexual health is human rights. And we need to promote a healthy environment and direct the tools that we've got at STI epidemics. So that's why we've written evidence-based guidelines as much as we can. So as I said, it's a shameless promotion of those. We've also got the New Zealand Guideline 2017 commentary is in process for the management of gonorrhea in response to the World Health Organization call for drug resistance. The New Look NZSHS website has put them, I couldn't snapshot the entire website because the printing would have been too small, but I do urge you to go and have a look at that. We've changed the sections and we've changed the order, and that each guideline has a summary, a longer guideline, a patient information sheet, and a contact tracing letter attached to that. This could not have been done without the absolutely fabulous help of Hayley Samuels, who's in the audience here, our wonderful project coordinator, and with her many other hats, is also director of the STI Education Foundation, and they manage the Herpes Foundation and the Wart Virus Project, both of which have got beautiful guidelines that are also out on the websites this week. We used to get those in printed form. These are now electronic, so I'd urge you to have a look at those as well. If you don't want one of these for yourself, as some of these, then do disseminate them to your practice nurses. I'm not going to say anything more about the HPV. Other people have covered those, other than take this opportunity to actively recall men who aren't at school. So any man who's less than his 27th birthday, call them into you on purpose and take that opportunity to do other STI testing. When I said that to Dunedin conference, they looked at me like, you know, I had two heads because they didn't want to tout for extra work. And I think we have to think about how we're configuring primary care these days, because 10-minute appointments is everything that sexual health is not. So Anne Robertson was talking about the International Union of Sexually Transmitted Infections, which is the Asia Pacific region of the WHO. We're having the joint conference next year with ASHM, the NZSHS and this group, and it would be a fantastic opportunity to go and see what's going on in China, the Solomons Pacific Islands, and it's at the Pullman Hotel in Auckland. So the Just the Facts consumer website is supposed to be enabling patients as well, and I think that's really important, that with the lack of sexual health literacy and the guidelines that are there for schools, we're having to think smarter about how we can reach patients, and I think social media is really the way to go. So these are lovely videos on getting sexual health symptoms. Hey bro, you need to have a sexual health check. They're herpes, myths versus facts, a very nice one of two ladies in the toilet talking about the morning after pill, and another one which I like about consent versus I'm not so keen, because the police video from the UK about consent in a cup of tea didn't gel with the vulnerable youth population that Lynn was, because they didn't really get it, they don't really drink tea. And so this is possibly more appropriate to a New Zealand cultural context, who knows? So do take a look at those. They were done by Theta Workshop. Thank you, Evelyn Mann and the rest. And as I said, guideline editing throws up what you don't have. We don't have how to take a sexual history because it doesn't lend itself well to an A4 page or less. The other thing, we don't have a transgender thing here. So we're borrowing heavily from overseas, and this iriseducation.com.au was in response to Australian general practitioners crying out for transgender training, and Edward and myself attended that weekend course, and it was really excellent, and it attracts GP CME points. There were general practitioners that were from Wellington on that course, and that's a lovely little thing that you can laminate and put in your waiting room for your patients. We've tried very hard to embed guidelines as much as we can with electronic referral pathways, because we talked about the fact that you can make guidelines, you know, coming up your eyeballs, but unless they're in use, that's not going to be helpful. So many of you have got electronic health pathways in your DHB. Otherwise, have a talk with us and we can send some passwords out, and you can remotely access the CDHB intranet. This one is actually about long QT interval, so it gives us the ability to liaise with other disciplines such as cardiology, urology, gynecology. and there's community health pathways and then hospital health pathways. It also is a great way of meeting your colleagues. So I can see I'm nearly out of time. So we talked about the New Zealand AIDS Foundation, and I spoke to a friendly pharmacist because the Truvada drug patent expired in August 2017, so he's honour bound to try and get Truvada generic emtricitabine tenofovir in his pharmacy for this conference, but actually there's some Pharmac paperwork that has to be completed, so hopefully in the future we'll be writing a prescription and just sending down to the chemist instead of importing online. And this was the ASHM prep and practice module that Edward so competently produced with the rest of the New Zealand AIDS Foundation to have a New Zealand commentary on the Australasian website for general practitioners to be able to do an online module. Basically what I'm talking about, really everything boils down to very wordy thing, and that we tried to keep everything A4 page or less, which means that there are quite a lot of words, but there is a lot of devil in the detail, and you can see this is sexual health check on page 13, and page 14 is contact tracing partner notification. So if you read everything on that, but I mean just at a glance you can see that there's a different sexual health check dependent on whether you're an asymptomatic female, opportunistic test, whether you're a symptomatic female, whether you're an asymptomatic male or an opportunistic test, and there's some interesting thing about males presenting to you for other reasons may not be asymptomatic, and whether there's a symptomatic male who has sex with females, and then if you're a male who has sex with men. So immediately it shows you that you have to triage people into which kind of sexual health check you're going to do just by eyeballing those boxes. And as I said, there isn't a A4 sheet on how to take a sexual history, because a bit like doing your mihi, it's actually a process. And so what we've done for primary care is we want a quick and dirty, less than 5 minutes, done in the waiting room by the practice nurse. You can not pass go, do not collect 200 kind of thing. So we have done one of those, and it's called an STI testing questionnaire. We did not call it how to take a sexual history. And basically, it's what we use for our express clinic testing in the sexual health clinic. So it's got yes, tick, 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 boom, which swabs you're going to do and which orifice, whether it's oropharyngeal and anorectal, are required, as well as your genital swabs and your serology. But good sexual health, to be honest, is a lot about prepping the patient's expectations before they even walk in the door, through implicit and explicit messaging. So whether you're at a bus stop, whether you're free of charge, whether you have disabled car parking, whether you have Women's Weekly, and we heard about that being the anniversary of Women's Weekly, it's a dreadful magazine. If you can have other magazines, and you must have explicit signage on posters and genital diagrams that are both culturally appropriate and gender appropriate all over your walls. Whether you have confidentiality, whether you know your laboratory, and whether you have good reception. So that if you then launch into a discussion about anal sex contact, it's not a bolt out of the blue and you're going to get an offended reaction. So the summary is all men who have sex with men require pharyngeal and anorectal gnat swabs regardless of practices and regardless of condom use. There's insufficient testing to recommend throat swabbing in females other than for gonorrhea contacts or sex workers, particularly sex workers who specialise in oral sex. There's some evidence that anorectal gnat swabs should be routinely performed in females. There is some data to suggest that, but currently our national guidelines are not recommending it other than for testing females who actually report receptive anal sex, which means you have to ask. There's insufficient evidence to recommend pharyngeal or anorectal testing for men who have sex with women, but as I say, for all men who have sex with men, whether or not they also have sex with women, all have to have that. Males who attend a GP for reasons other than sexual health should be actively targeted for opportunistic STI testing. We've raised the age of screening, as I said, to 30 years of age, aligned more closely on purpose with our Australasian better funded guidelines, because we are not sure moving forward what this enduring process will be of guideline development. All persons having an STI testing have to have their serology, so follow how to do a sexual health check on page 13, and targeted hepatitis C, IV drug users, incarceration, HIV positive men who have sex with men, Hep B and Hep A. So for ease of use for primary care, because it's too confusing to do 1 month for this, 6 months for that, and 2 months for that, and because it perfectly fits with the medtech templates, which is the electronic record-keeping system most used in primary care, contact tracing for all conditions is 3 months. So that is a departure from the ASHM guidelines. So that means the look-back interval for all of the conditions that you're tracing is just 3 months for everything. There's no Mycoplasma genitalium guideline, you'll notice, due to regional laboratory testing disparities. So we've covered that in our refer. Refer persistent NSU, refer PID that isn't resolving, refer epididymoitis that isn't resolving, and then we will do that testing for you. We've not added azithromycin, unlike ASHM, to gonococcal pelvic inflammatory disease or for epididymitis for lack of evidence of efficacy, because particularly with pelvic inflammatory disease, in adding in azithromycin to an already quite long course of antibiotics that make you feel sick in the stomach reduces your compliance, and because in actual fact we have relatively low rates of gonococcal PID and gonococcal epididymitis. Community prevalence studies have shown that gonococcal is the least prevalent. It goes chlamydia, the top, followed by mycoplasma, followed by trichomonas, followed by gonorrhea. So that is a departure from ASHM, and we're following the BASH. So the thing that should be at the very top there is actually the clip which I have inferred is actually the clinical guidelines writing group. They were immensely helpful. They took guidelines each and they fed them in. The Christchurch Sexual Health has been fantastic, and the clinical director, Dr. Edward Coughlin. I went in the other day to quickly download my PowerPoint, and there was Lynn answering the Facebook, and Huwina was on reception, and Debbie was scurrying around getting some things for Angela, and I just thought, what a great team. You know, this is when the conference was on, everybody was still back at work. Hayley Samuels, absolutely invaluable, the STIF Foundation, Julie Crichton, the laboratories, ESR, Jill Sherwood, so New Zealand AIDS Foundation, everybody I've borrowed slides from. So as I say, the summary and the longer guidelines on the website, plus the Herpes and Warts Foundation, and you're very welcome to contact us.
Thank you.